Next, we're going to be talking about bowel needs. We're going to be talking about bowel elimination for our patients or residents. So when we're referring to bowel elimination, we are going to be looking at how someone eliminates the leftover food products that they can't digest. So normally, when we're talking about the gastrointestinal tract, you start taking in your food, you eat your food, you swallow it, goes down your esophagus into your stomach. Stomach starts secreting acids to start breaking the food down, and then it goes through the small intestines where the nutrients start getting absorbed, and then the large intestines where water reabsorption happens. Whatever is left over from all the foods that we take in is going to come out in the form of a bowel movement. Now, some people have a bowel movement every day. Some have it 2 times a day. Some people have one every 2 days or even every 3 days. So everyone's normal is different. So the nurse will generally find out on admission. So when an RN does an admission assessment for a resident, they're going to find out what their normal bowel elimination pattern is and what they have to do to help maintain that. And then we will help follow that as much as we can to help keep them as regular as possible. Stool generally is brown in color, it's soft, and it's formed and shaped like the rectum. And of course it will normally have an odor to it, and that's because you have bacteria in your intestines. You have bacteria in your gut to help you digest your foods. So when you do have a bowel movement, the reason the odor is there is because of that bacterial action. So when we were looking at, we said our gastrointestinal tract, we start with the mouth. Food comes down this esophagus into the stomach. Nutrient absorption starts happening in the small intestines, and then the small intestines links over here to the large intestines, and generally water reabsorption is going to happen here. Whatever's left is going to come out the anus, which is the opening to the rectum, and we'll have the bowel movement. So observations. Now, I know we don't normally like to look at other people's bowel movements, but we do need to observe certain things, because when you're looking at someone's bowel movement, it does tell you quite a bit about their general health. So the color of it, we expect it to be brown. So what if it's not brown? What could that possibly mean? It might mean, if it's green, maybe they've had a lot of green leafy vegetables. Maybe they've had a lot of, green colored foods. It might be kind of a darker color, let's say a really dark, almost blackish color. So when we see things that look almost kind of black and tarry, a lot of times that means they might be bleeding in their stomach. And when it's more of a maroon color, it might be more from the small intestines. And if you see bright red blood in the bowel movement, you might know that they might have hemorrhoids or something right around the rectum. Some people, when they have liver issues, they'll have their stool will kind of come out to a gray, kind of a clay gray color sometimes. So observing the color is an important thing to do, and if you're seeing something that doesn't look like a normal color, before you just flush it down the toilet, you're going to want to make sure you point it out to the nurse. The amount. So we said everybody's normal is different. So some people will have a bowel movement every day, some people every 2 or 3 days. But is the amount that they're having, is that consistent for them? Is it a, are they going much more frequently than they normally do? Are they not going as much as they usually do? The consistency, is it hard and dry? Is it liquidy? So when things sit in the gut too long, so when things are moving very, very slowly through the intestines, there's a lot of time for extra water absorption to happen. And so what happens is if things are sitting in the gut for too long of a period of time, water reabsorption is happening and the stool tends to get kind of hard and dry. It is not unusual with our elderly population to see them have problems with constipation, which is dry, hard stool. And part of that is because as a person ages, peristalsis, those wave-like contractions that help move things through the gut, peristalsis decreases. Another reason we see this happen is a lot of our elderly population, they don't like to drink as much water. They don't want to have to go to the bathroom as much. They don't want to, especially if they have incontinence issues, they don't want to soil themselves, and so they will purposely not drink as much. But if they're not taking in as much water, your body is going to try to reabsorb as much as it can, and that's going to make that stool become harder and drier. Another reason we can see constipation is because activity sometimes decreases as people get older, especially in the nursing home if they have disabilities and they're not moving around as much. That also decreases peristalsis. On the other end of it, looking at consistency, is we'd want to make sure that it's not liquidy, that they're not having problems on the other end of that they're not having diarrhea. Maybe they ate something that didn't agree with them and things are moving too quickly through the gut for water reabsorption to happen. We also look for that presence of blood or mucus. So it's normal to shed a little bit of mucus when a person has a bowel movement. Your rectum will shed a little bit of mucus just to help things kind of pass through. But if it's real mucusy and stringy, or again, if you see blood, either the dark black and tarry, or whether you see maroon or you see bright red blood, we'd want to make sure we point that out to the nurse and let the nurse take a look at it before we flush it down the toilet. We expect stool to have an odor to it. So again, you have bacterial action in the gut, and that normally will produce an odor. But if it has a really unusual smell, so for instance, C. difficile, Clostridium difficile, is an organism. It's a bacterial spore that when it gets in the gut, and usually we see it happen to patients that have been on heavy-duty antibiotics, because antibiotics not only kill good bacteria, not only kills bad bacteria, it kills the good bacteria that's in your gut. That helps you with digestion. So what happens is the bacteria is killed off, and then you're more prone for other bacteria to come in and to cause a disorder in that gut. And so one of the things that happens is with Clostridium difficile, it has a very, very unusual smell. It will cause the person to have diarrhea, and the odor will be very, very distinct. Once you smell it, you'll probably always remember it. So when you're smelling a really unusual smell to the bowel movement, again, that is something you'd want to point out to the nurse. The shape of it, normally it's the consistency of the rectum. If it's really hard and dry, it might be, really hard, round, dry things, or a person can get impacted where they just have this big bulk of stool that just kind of gets stuck up there, and so what's coming out is you'll actually notice that it becomes really hard and misshapen. The frequency of it, are they going the amount that they usually do, and are they complaining of any pain or discomfort when they have a bowel movement? So if there's something that you think doesn't seem right or it seems abnormal to you, you want to talk to the nurse about it and have them take a look at it. So things that could impact bowel elimination, well, privacy is one thing. So if we think about it in the nursing home situation, there's usually semi-private rooms. So you're in taking care of your patient and they need to have a bowel movement, and let's say they can't get up to the bathroom and so they need to use a bedpan. And right next door is the other patient, and maybe that patient has family members that have come in. It's going to be very humiliating for a person to try to have a bowel movement knowing there's a person right next to them and visitors next to them that could hear sounds, smell, a bowel movement smell. So privacy really has to be something we protect. It is okay to ask family members to step out of a room while someone else is using the bathroom. That's absolutely an okay thing to do. Habits, what are their normal habits? So do they normally have to do something to help themselves have a bowel movement? I know some residents, they have to have prunes in the morning and then hot coffee, and they have this little regime or routine that helps them have a bowel movement. Hot drinks, hot coffee, hot teas, that actually activates peristalsis and helps things move through the gut. So a lot of people will ask for a hot drink. High fiber foods are very good for helping bowel elimination. And so fiber is not a nutrient. Fiber is the part of the fruits and the vegetables and the grains that your body cannot digest, cannot utilize. But what it does is it helps things move through the gut so they just don't sit overly long in the intestines where more water reabsorption could be happening. We mentioned green vegetables can cause the stool to look green. Red Jell-O tomato soup can make it look red. Milk products can cause diarrhea for some or excessive gas for others. So we kind of need to find out if there's certain dietary restrictions or certain diet things that make them feel very uncomfortable. We can always try to avoid that for them. Lack of water, as I said, it will make the feces hard and dry, which is known as constipation. And warm fluids, again, can activate peristalsis, can help things move through the gut. Activity is very important for normal bowel elimination. Exercise maintains your muscle tone and it aids in peristalsis, those wave-like contractions as things are moving through the gut that help things move through the intestines. So that's very important for normal bowel elimination. And then certain medications can cause either constipation or diarrhea. So as I mentioned with antibiotics, it doesn't only kill bad bacteria, it kills good bacteria. And so if you don't have good bacteria in your gut, you're going to be more prone potentially to getting diarrhea. Some medications, like pain medications, especially narcotics, if a person's having a lot of those can actually cause constipation. So we have to be aware of the medications that the nurse is giving them can also impact a person's bowel elimination. Any disabilities they've had, and just as I mentioned, the aging process, things tend to start slowing down a little bit, and that goes for their bowel elimination as well. So the term constipation is passing hard, dry stool, and it occurs when things are moving too slowly through the bowel. Causes can be a low fiber diet, decreased fluid intake, and inactivity. Those, when a person's having an issue with constipation, the first few things that we usually recommend for them is increase their fluids, increase their fiber, and because you never want to increase fiber without increasing fluid. You can actually get them more compacted there. So increase fluid, increase fiber, and get them walking, get them moving as much as possible, and a lot of times that will help take care of it. Ignoring the urge. So when people know they need to go to the bathroom but they keep holding it, they keep ignoring the urge, sometimes it can actually rebound on them and cause them to be constipated. Medications, as I mentioned, especially narcotics. Aging, so again, peristalsis decreases. And we have to remember, when people come into the nursing home, a lot of times they come in with a disability, so they go on different dietary changes. They're not eating the foods they're used to eating, or maybe their consistency of their foods have changed, and so sometimes those dietary changes can make an impact on them as well. So constipation treatment, fluids, fiber, activity. Those are the first things we want to start with, and then if that doesn't help, then a lot of times the physician will order stool softeners for the resident or the patient that the nurse would give, laxatives or suppositories to actually help them go, and enemas. And we'll talk about suppositories and enemas in a minute. But when a person's constipated, usually if after 3 days, so 3 days if a person cannot have a bowel movement, we need to start thinking about giving them something or helping them with this process so it doesn't get so plugged up that they get what we call a fecal impaction. So the fecal impaction is a prolonged retention and buildup of feces. Feces is another name for bowel movement or for poop. So it's a buildup of this stool up in the rectum, and it gets really hard and dry, and it almost makes like this putty-like mass. It's just like this big mass of stool. And liquid sometimes can actually seep around it. So sometimes you'll actually have liquid kind of oozing out around it. So when you see liquid, and I'm not talking about if the person's having diarrhea, they just have little bits of liquid kind of oozing around this, and they're complaining of having abdominal cramping or distension, or they haven't been able to have a bowel movement properly, you need to let the nurse know, because they might have a fecal impaction. And what they do for that is the nurse will put on they'll put gloves on, and they'll lubricate their finger with KY jelly, and to lubricate it, and they'll actually stick their finger up into the rectum and see if they can feel it, and see if they can actually pull some of it out to kind of get some of that mass out of there. Now it says here we would check a heart rate before doing this. When we get to vital signs, we'll talk about this, but you have what we call the vagus nerve. And the vagus nerve actually runs from the heart, and it goes all the way down to the rectum. And when the vagus nerve is stimulated, it can actually slow the heart rate down. So before you would put things up in the bottom, you'd want to make sure that the heart rate is in a normal range. So the nurse the nurse does this. The RN or the LVN will do this, and they'll put their finger up there. They'll try to pull as much of it out as they can, and then they'll usually give the person a suppository or an enema to try to get the rest of it out. Now diarrhea is the other extreme of this. That's frequent passage of liquid stool. and feces, or that bowel movement, move through the intestines so rapidly that there's not time for fluid reabsorption. And we said usually fluid reabsorption happens in the large intestines. So the person can have abdominal cramping, nausea, vomiting can occur. So we want to make sure, especially when a person is having diarrhea, that we're really careful about answering their call lights as soon as possible. And when they need to go to the bathroom, they're going to need to go right then. And so doing hourly rounding on them, checking them frequently to see how they're doing, answering their call lights in a quick manner is going to help tremendously. The other thing we always worry about with diarrhea is dehydration can occur, especially for these elderly residents who are already, I told you, they already tend not to drink enough fluids because they don't want to end up being incontinent of urine all the time. So a lot of our elderly population are mildly dehydrated anyway, and now they get a diarrhea and they can become dehydrated really quickly. So fluids become a really big issue for these people. Now, the term fecal incontinence means inability to control the passage of stool through the anus. So when we talked about urinary incontinence, not having control of the urination, this is not having control of bowel movements. So it may be from intestinal disease, and sometimes we see it from nervous system disorders. We'll see patients that have neurological issues, nervous system disorders, where the communication from the brain to the body isn't working correctly, and you'll see that they don't have control of their bowels anymore. It can happen from a fecal impaction or from diarrhea, especially if they just can't get help quick enough. Some medications can cause this to happen, illness, aging, and a lot of times it comes back to just not getting help in time. The term flatulence is a fancy word for gas. So flatulence is the excessive formation of gas. And you know what? When a person is full of gas, they feel really uncomfortable. Their abdomen can kind of bloat up. They feel really, really bloated and full, and they feel like they need to pass gas. But if they're having a problem with it, the best thing you can do for them is exercise. Get them up walking, because that just starts moving that peristalsis. It starts moving that extra air out of them. And a lot of times they can pass the extra gas with exercise. If not, sometimes they have to do an enema to help get the excess gas out. So bowel training is what we do when we're trying to help a person gain control of their bowel movements again. So it's to help develop a normal pattern of elimination. So what happens is, let's say the person has been having difficulty going to having bowel movements, they're not having them regularly, or they haven't been having good control because they're really sporadic. What they can do is they can try to get the person into a normal pattern, get their bowel habits back into a normal pattern of going. So one of the ways they do this is they find out what time they normally used to go. So a lot of people go in the morning after breakfast. So after breakfast, they've eaten some food, they've had a cup or two of hot coffee, and that has increased peristalsis. And so that's a fairly typical time for a lot of people to go to the bathroom. So if that's their normal time, after breakfast and their cups of coffee, the nurse will take them back to their room and they will give them a suppository. It's a cone-shaped medication that's inserted into the rectum, so the nurse puts gloves on, lubricates their finger and the suppository with KY jelly. They stick it up the rectum as far as they can reach, and it takes about 25 to 30 minutes for it to melt. And so it's going to melt in the body, and what it's going to do is it's going to start, they're usually made of, most of them are glycerin suppositories, and it causes the bowel to contract in response to it to try to push things out. So hopefully that will make the bowels kind of contract, and the person will be able to have a bowel movement. We will do that at the same time for 3 to 5 days in a row, at the same time each day. Increase their fiber, increase their fluids, increase their activity, and give them a suppository for 5 days in a row, and try to get the bowel back in a normal habit of going again at a normal time. And by doing that, a lot of times you can just get the bowel back into a normal routine or a normal habit. This is what the suppositories look like. As I mentioned, it's just kind of this rounded, kind of cone-shaped medication. Put KY jelly on it, KY jelly on the finger, and they just insert it as far up in the rectum. Some people do it to themselves. And after about 25-30 minutes, it melts in the body, and it should stimulate the person to go to the bathroom. So as a CNA, even though we're not going to be the ones inserting it in there for them, we need to be ready to answer their call light, because when they need to go, they're going to need to get to the bathroom. Now, an enema is an introduction of fluid into the rectum and the lower colon. Now, I will mention with enemas, by state law, we are allowed to give them, but it is also going to be up to the facility where we go. So I know the facilities where we take our students for CNA, they do not allow their CNAs to do enemas, but if you get a job as a CNA working in a hospital, a lot of the hospitals around here do allow them to do it. So you're going to need to know what the facility's policy is. But we usually put them in a Sims position. So you put them on their left side and you sharply flex the top leg, and that makes them kind of roll, half on their side, half on their stomach. And then they make what we call small volume enemas and large volume enemas. So small volume enemas are just a preset amount of volume. It's usually about 120 milliliters of volume. The end of this cap is already lubricated with KY jelly. You put gloves on, you roll them over into that Sims position, and you insert the fluid into them, and you pull it out before you let go. So I squeeze the water into it. I don't want to unsqueeze it while it's still in their rectum, because it'll try to suck the fluid back out. I want to squeeze it down, pull it out, and then I can let go of it. You tell them to hold it in the rectum for as long as they can, and then as soon as they need to go to the bathroom, then we'll help them and assist them into the bathroom. So doctors order the type of enema that they're going to get, but CNAs do not give enemas that contain drugs in them. So I said by law you're allowed to give an enema. You're allowed to give a tap water enema. You're allowed to give a Castile soap enema, where they put this mild soap, it's called Castile soap, and you add a little bit of it into the water, and when you insert that up into the rectum, it makes the contractions even harder and more intense to help push things out. And sometimes they'll do what we call a mineral oil enema, and a mineral oil enema will actually kind of lubricate the rectum. So especially if they have a bunch of they're full of dry, hard stool, it can be kind of painful when they pass that out. So doing some mineral oil up in there along with the water can kind of lubricate things so it comes out a little bit easier. We do want to make sure that the water temperature is the correct temperature. It should usually be lukewarm. It should not be hot. And so that's just a small volume enema, just a preset bottle of a certain amount of fluid in it. A regular enema, the physician would order how much they want, whether anywhere usually from 500 to, I've seen them up to 1,500 milliliters of fluid at a time. So you fill it up in a bucket or a bag. It's usually this tubing is going to be clamped. You put the person over in a Sims position, and you insert the tube in about 2 to 4 inches, so it should be lubricated with KY jelly. You insert it in, and then you want to raise this bag about 12 inches from the rectum area, or about 18 inches from the bed, and you let it run. You unclamp it and you let the volume run in. Now, if the person starts feeling uncomfortable because they're getting a lot of volume up in their rectum, and it's like, oh, this is uncomfortable, you know, it's making them feel awful, you go ahead and you just clamp it, and you just stop, and you let them take some nice deep breaths, and then after that cramping subsides, we can open it back up and just go at a slower rate. If it starts causing cramping and difficulty for them again, you need to just take it out and let the nurse know how much you were able to give. You're going to tell the person to hold it into the rectum as long as they can, but they are not going to be able to hold it for very long, so you're going to put a lot of volume in there. And so when they feel like they need to go to the bathroom, they're going to need to go. They're going to feel the need to go, and they're going to need to go right away. So you're going to need to be ready for that. Now, the person with an ostomy is a surgically created opening. And so the opening is called a stoma. So a colostomy is a surgically created opening between the colon, the large intestines, and the abdominal wall. An ileostomy is the opening from the ileum of the small intestines to the abdominal wall. So here you have your stomach, and then from the stomach things go through the small intestines, and then the small intestines ends in the ileum of the small intestines, and that's connected here to the large intestines. So if the person, let's say the entire large intestines was diseased, this part here is where they would do an ileostomy. They would bring the ileum up to the surface of the skin, so the stoma would be to the surface of the skin, and all of this large intestines would be gone. Now, if we think about what we said the large intestines does, we said most of our nutrients are absorbed in the small intestines, and then water is reabsorbed in the large intestines. So if we don't have the large intestines there anymore, we aren't going to have a lot of water reabsorption happening there. And so what will happen is the stool is going to become more loose. It will be kind of a loose, almost an oatmeal consistency to it. It's not going to be nice and formed anymore, their bowel movement, because it's going to be it's going to have a lot of liquid to it. If the person's colostomy is, so let's say here's where the ileostomy connects to the large intestines, and this part of the large intestines is good, and this part is good, and this part here was damaged, and this is what they had to cut out for some reason, maybe due to cancer. And here's my stoma. So now the stuff that's going to be coming out of here, it's had time for some water reabsorption. So there's going to be some formed bowel movement to that. It may not be all completely formed, but there's going to be formed pieces to it. So the more of the large intestines that is left, the more normal and natural the bowel movement is going to look. Now the stoma does not hurt, so when if this gets touched or something, the nerve endings are cut when they bring that stoma out, so it doesn't hurt when it's cleaned. It's not a painful thing. So the nurse, not you, but the nurse, the RN or the LVN, will change this dressing that goes around the stoma. So there is it's called a skin barrier, and it has a flange on it, and the bag, the bag that is going to collect the stool, or that's going to catch the stool, is going to attach to that flange. So the skin is actually clean. Usually the treatment nurse will change it, and they will take off this skin barrier and this flange, and usually they change it about, well, it says every 2 to 7 days, but 3 to 5 is pretty common. So between 3 and 5 days, they're going to take this flange off. They'll clean it really well. They'll clean the skin and check the skin, and they'll put a new skin barrier on there. These bags here, some of the bags have clamps on the bottom. So if the bag has a clamp on the bottom, once it fills up with bowel movement, so the bowel movement is going to come through the stoma and into this bag. Once there is bowel movement in there, we can empty it. So we can open up this clamp and actually empty the bowel movement, and we can just do it right into a bedpan. Of course, you'd have gloves on, and you can just empty it right into a bedpan and then go dump it in the toilet. Some of the newer systems, you just change the entire bag. So some of the newer bag systems, they don't even have this clamp on it. Once there's bowel movement in it, you just pop off this thing off the flange, get a new bag, and attach the new bag to it. And so that's not a painful process. Now, if these bags fill up with gas, so if the person has a lot of gas and this bag is filling up with gas, please don't poke a hole in it. You can just open it. You can actually break the seal on the flange, or open up the clamp on the bottom. Just let the air out and then clamp it back up. So colostomy pouches are usually emptied when there's stool present, or if there's a bunch of loose liquid stool in there. If it's just loose liquid stool coming through, when the pouch gets about 1/3 to 1/2 full, we want to make sure we get it emptied. The pouch itself, we said, is usually changed every, I think your book says 2 to 7 days. I would say 3 to 5 days is pretty common. Odors can be prevented by good hygiene, emptying the pouch frequently, avoiding gas-forming foods, and they do actually have some little deodorant tablets that you can drop in the bags. I've never really seen those much in the nursing home though, but some residents may have them. They can wear normal clothes over it. You can empty the pouch, but we don't, the dressing, the wafer skin barrier that goes around it, the treatment nurse does that for us. Some people will just empty the colostomy right into the toilet. So if the bag is full, they can just empty it right into the toilet. But usually if you're emptying it especially if they're laying down in bed, I would just put it in a bedpan and then just take the bedpan over to the toilet and dump it. And then some people who have this is a colostomy bag that's attached over that stoma. Some people like to put it in these little, oh, it's just like a little cotton protector, I guess you would call it. It's got a little pouch that they can stick the bag in it, and then it adheres here, so that way they don't accidentally catch this on anything or accidentally have it pop out if they're, especially if they're, if this patient goes home, you know, if they're going out to eat with their family or something like that, they wouldn't want this to catch on something and possibly pop off accidentally. So sometimes people will put it in these little pouches. So that is going to end our talk about bowel elimination.